what are our objectives today? So first, we're going to describe the presentation risks and guidelines for monitoring sleep disordered breathing or sleep apnea in people with Down syndrome. We're going to illustrate some of the current literature, what's on the horizon, and what's the point of doing what we do. What's some of the outcome data for treating obstructive sleep apnea in people with Down syndrome. And then we're going to demonstrate some of the challenges, but also some of the opportunities of current treatments for this population. And so we're going to start with just, and many people know this already, what are some of the health risks associated with Down syndrome? And so because we are mindful of what parents and caregivers have to do in terms of taking care of their loved one with Down syndrome, we know that sleep apnea, although it's a part of it, it's still a large part because it can affect these other organ systems. So obstructive sleep apnea, for example, can affect high blood pressure and cardiovascular disease. It can affect some of these other kind of organ systems. And so we still want it to be on people's horizon and try to take care of people with Down syndrome as we take care of these other things in conjunction. What is obstructive sleep apnea? And so obstructive sleep apnea is sort of a repeated collapse of the upper airway. And so a nice normal airway is going to allow air to come in during sleep. And when we sleep, things sort of relax and things can collapse if it's a collapsible airway. If not, it stays open, air gets inside, we get nice oxygen coming in, CO2 going out. And an obstructive airway, there is a collapse usually at where the arrow is, but it can be along any part of this airway here, and air cannot get in. It's obstructed. And then what does the body do? It says, I need to breathe. There's consequences to that. There's lower oxygen, higher CO2 because we can't get that air in. The brain says, I need to breathe. There's an arousal. So there's disruption from sleep doing what it's supposed to do. And instead of doing those things, it's working on breathing. That disrupted sleep is also affecting the next day. So the tiredness, the fatigue, some of the neurocognitive things that we see, as well as behavior. And then, of course, heart and metabolic changes, not just on that night, but in subsequent nights and all throughout if it's untreated long term. There are some definitions. I don't think we need to pay too much attention to, because even apnea, which is a complete stop, or a hypopnea, a partial stop, both of those things together lead to the things we talked about. And so we kind of lump those together and count them on a sleep study. And what we do is count them on a sleep test. You are probably familiar with something called the polysomnogram or the sleep study when people talk about sleep studies. The poly means many, so many different things go on. All of these things help us to determine not only the severity of obstructive sleep apnea, but other things happening in sleep. And so we do the EEG part and some of the stickers, and I always tell kids it's stickers, no ouchies, but sometimes people with Down syndrome still have some sensory issues. So we still are mindful of the things going on. We try to sometimes minimize it or have child life or child-friendly individuals help people with Down syndromes can keep things on. There's a cardiorespiratory monitoring, limb movements. And part of this is having a technologist with the patient and the caregiver, because the technologist will come in when things come off. And especially with people with sensory issues, if they were trying to pull things off, or if they don't like something, they might try to make it comfortable them, wait for them potentially to go to sleep, put it back on. And so that's happening throughout the night, and it gives us very valuable information. We are getting better at some of the home options, but we're not there yet. And we're still getting pretty good studies with the help of a pediatric friendly lab. And so we're able to do these pretty readily in our patients. But I do want to just mention that there are some home-based options. Many of them are for adults with, who are independent, who can push buttons and keep things on. And if that's a person that can get that done, great. And if not, we end up in the lab. And sometimes we're still not able to get good information, and so we're still doing the in-lab studies for pediatrics most of the time, and young adults with obstructive sleep apnea for their testing. And I'll hand it on to Dr. Shah.
Thank you so much. So in terms of diagnosis, I know when I see patients in the office, we have a chance to review the sleep study. And so it's important to distinguish if you hear a number and distinguishing between children and adults. So in adults, anything less than 5 is considered normal. And 5 to 15, that's the apnea hypopnea index, like Dr. Ibrahim mentioned. You combine the two scores with either a complete stop breathing or a slowing down breathing that's causing a physiologic change, so a stress to the heart or lungs. 15 to 30 is considered moderate, and greater than 30 is severe. And this is index per hour, so events per hour. In children, less than 1 is normal, 1 to 5 is mild, 5 to 10 is moderate, and greater than 10 is severe. Now, where we struggle sometimes is if you have a 17-year-old who's near adult size, I often have a very in-depth discussion with the family because though they might be classified as severe in pediatric world, they're a moderate or near mild in the adult world. So we have to take some of these criteria also on the patient's physiology, height, age, and weight as well. But the prevalence of obstructive sleep apnea in people with Down syndrome is quite high. So greater than 1, about 69%, and then greater than 5, which puts you at mild in the adult world and moderate in the pediatric world, more than 50%. Next slide. So general obstructive sleep apnea risk. So if we go in the general public, what is the risk factors for sleep apnea? In the adults, obesity. That being said, thin people can have obstructive sleep apnea because there's other impacting factors in sleep apnea. Age, male greater than female, craniofacial abnormalities, so a flattened face, short jaw, large tongue, smoking, fluid retention, race, ethnicity, and history of obstructive sleep apnea in children. When I see any patients with sleep apnea, because my practice is pediatric, I say, though we can cure or improve sleep apnea in childhood, you still can have sleep apnea as an adult. And that goes with all populations, children with Down syndrome and children with not with Down syndrome. In pediatrics, the biggest thing we look at is tonsil and adenoid hypertrophy. So that's because the tonsils and adenoids take up relatively more space in the mouth and the back of the nose than in adults. So that's why kids with large tonsils, we think about that in sleep apnea. Obesity, BMI, prematurity, especially children with lung disease, race, ethnicity, smoke exposure, and any comorbid condition. Neuromuscular tone, so how strong the muscles are of the back of the throat, the back of the jaw, also plays a significant impact. And we'll talk more about that down the line with some of the new technology in treating sleep apnea. And so this is just a picture of something I see every day. And when you have someone say, this is large tonsils, we grade these 4+ tonsils, so almost touching, essentially touching. So what are some added risk factors of obstructive sleep apnea in children with Down syndrome? So we talked about not only kind of the physiologic, large tonsils, what that does to the airway, but we also talked about craniofacial, so facial features, mid-face, so cheekbones and jawbones. So generalized hypotonia, so the muscles of the tongue, jaw tend to be what we call hypotonia, so a little weak, so floppy. Flat face, so mid-face hypoplasia is just kind of the flattening of the cheekbones. That leads to decreased airway and breathing through the nose, more airway resistance. Micrognathia, so small jaw. Once again, that the jaw is attached to the tongue of the muscles attached to the jaw. So if the jaw is small, that leads to more of the the tongue falling back. Smaller upper airway, adenotonsillar hypertrophy. So same thing, they're at high risk for enlarged tonsils and adenoids. Glossoptosis means the tongue kind of flopping back. And added to this, hypothyroidism can also lead to obesity and also kind of some decreased tone, obesity, and airway abnormalities such as narrow nasal passages, laryngomalacia, tracheomalacia, and even smaller airways. Sleeping, remember, sometimes the goal of sleep is to get in the most comfortable position as possible. And so often what we see in children with Down syndrome is different sleep positions. There's the pretzel position, the sitting forward, and sitting and kneeling forward as well. And so that's all in ways to really minimize the tongue falling back and opening up the airway as naturally as possible in these positions. Dr. Ibrahim, your turn now.
Okay, thank you. And so what are the guidelines on obstructive sleep apnea in Down syndrome? We're going to first start with children because that's where the guidelines are more robust. So the American Academy of Pediatrics over time has put this out, and the most recent one was in 2022, saying that we should be looking at getting a sleep study between the ages of 3 and 4. Obviously, clinical judgment before that and after that, but by that age, because of the high prevalence, like Dr. Shah mentioned, 50% more, moderate at least, will need to have a sleep study because with that high prevalence, we don't want to miss the opportunity to treat children, especially since we have surgical intervention at this young age where needed. So we need pediatric friendly labs, and thankfully we have them all in the area. Rainbow's one of them, but of course our colleagues and our partners in the Northeast Ohio area are also doing studies for children with Down syndrome. So we're casting the widest net to hopefully help reach access for patients. Beyond that age, it doesn't mean that we don't do sleep studies. We've had a healthy conversation about this. Well, what if they become 5 and, do they just suddenly not need a sleep study anymore? No, of course, we want to have a reasonable understanding of if they've never had one, really considering that. But if they've had one and now they've had their tonsils removed, or what do we do now? Well, at every visit, we still want to reevaluate having the obstructive sleep apnea symptoms if they were present, or looking for other things that might be affected by sleep apnea, like, for example, higher blood pressure, et cetera. And if somebody's had an abnormal test and hasn't addressed it, we still want to follow that up at all the health supervisions that we encounter. And when there's abnormalities or concerns, we want to refer very generously either to a sleep specialist or to ear, nose, and throat, like Dr. Shah. I also want to discuss obesity, and then, of course, restless legs were in these guidelines. So just putting that in here in the case, that's something that I would potentially do in clinic. Now, when we get into adulthood, there are some guidelines, as everyone knows, but interestingly, sleep apnea is not a line item like it is in childhood. It's not to say that it was ignored. No, in fact, it's actually spoken about quite a bit in many of these recommendations. So if you look at cardiovascular disease, for example, there's a discussion about looking at sleep apnea, but it still needs to mature over time because the data is increasing that we need to look beyond childhood and after an adenotonsillectomy because the prevalence still remains pretty high. And thankfully, there's a global Down Syndrome Foundation looking to improve the medical guidelines, excuse me, and promoting more work in this area. And on a national level, thankfully, the NIH is doing more work to budget and give and provide for research in this area to help people identify where the knowledge gaps and the care gaps are. And so why care, Dr. Shah?
Okay. Oh, sorry. What are some of the consequences of obstructive sleep apnea in Down syndrome? So why do we care so much at focusing on treating sleep apnea? It's multifactorial. It impacts every system in the body. So why is OSA bad for you? When we're obstructing at night and having desaturation events, meaning the oxygen and concentration in our blood is dropping, that leads to a compensation of high carbon dioxide, waking up, fragmented sleep. I always tell families, imagine setting an alarm on your phone every 10 minutes and it going off. How well are you going to feel the next day? Probably not so good. So these arousals and sleep fragmentation increases the stress in the body, and the entire pressure of the chest and the body's change. That can impact also blood pressure as well. So the stress that it puts in the body creates inflammation, platelet aggregation, meaning that the blood is a little bit thicker, high blood pressure, what can happen with high blood pressure, increased risk for heart disease, stroke, diabetes, ultimately what we call heart failure, pulmonary hypertension, arrhythmias, and ultimately it can lead to mortality. What does it do to the blood system? Once again, inflammation creates endothelial dysfunction, meaning that the lining of the blood vessels once again get thickened and are high risk of stroke and clot and atherosclerosis. So children in Down syndrome and OSA, what other impacts if there's frequent night wakings and oxidative stress, meaning stress on the system? What else can that impact? Well, development and behavior. So we know having OSA or having more apnea and
I don't have
hypopnea.
make sure my camera's off.
Is someone?
I think they just muted. Mhm.
Oh, perfect. So having OSA, what other kind of behavioral consequences? Well, if we're constantly getting awoken at night to obstruction, there are behavior consequences. So in children, we often see this manifested in ADHD, difficult to redirect, disciplinary issues, and negative behaviors correlate with higher sleep apnea and worse development. So as we stress our body throughout every night of sleep, this can impact development, language acquisition, lower vocabulary. We're always a bit slower when we haven't slept well or slept at all. So how is this all determined? There's cognitive IQ testing. We know that the IQ score, verbal IQ score, was about 9 points lower in children with OSA, mild OSA, greater than 1.5 versus no OSA, and worse executive functioning in kids 6 to 12 years old. Once again, this impacts working memory, emotional control, poor cognitive flexibility. So pretty much if we talk about learning, the job of a child is to learn, get educated, and learn to be a strong member of society, however best way that's possible. And if we're impacting our sleep, that can impact day-to-day living. So can we impact cognitive development if we adequately treat OSA in younger children with Down syndrome? Dr. Ibrahim, we have a study looking at this.
We have a study looking at this, right? And this is not just our center study, it's a multi-center study across the nation. And it's an NIH study. It's called the DOSA study. It's actively recruiting, and we're partnering with all the institutions in the nearby area as a team approach. We are housed under Rainbow because we have to have one person kind of doing it at one center. So it is at Rainbow. But if anyone's interested, I'm working with Dr. Wong at the Cleveland Clinic and Dr. Laura Goldman there, Dr. Carter and others at Metro Health and Dr. Krishna Akron Children's. And because we know that the care across Northeast Ohio is all at every institution. And so we work along, we don't want to work along silos. We want to be able to house a study like this and give the opportunity for people with Down syndrome. It is only for kids 5 to 17, and it's looking at, so after Dr. Shah or someone takes out the adenoids and tonsils, there is a high residual obstructive sleep apnea. And the question is, can we impact neurocognitive functioning if we treat that and not ignore it? Because we know that in other studies and in typically developing children that we can potentially impact some behavior and some other things. And so we want to improve that opportunity for children with Down syndrome and maybe prevent things down the road if we can. And so the study is going to be looking at oxygen therapy as a treatment for obstructive sleep apnea in those who are not on things like CPAP. If there's people using CPAP, great. But we understand and we recognize that not everyone can. And so we wanted to have, as a nation, an opportunity to see if there's another treatment option for children with Down syndrome as they grow and develop. We also want to say, thank you for being involved with the HELP DS study. This was a study pre and post surgery for obstructive sleep apnea. The data, unfortunately, is pending, so we couldn't share it with you today. But it was very helpful to see, patients and families respond to HELP DS, and hopefully we can provide that information to you in the near future.
So good questions from the audience. So we're going to go a little through CPAP, so we'll be a little more detailed. But someone asked what oxygen therapy is. So Sally, if you can kind of go through that a little bit with the audience.
Sure, absolutely. So, one of the problems with obstructive sleep apnea is we obstruct our airway. We can't get air in, and then we don't get enough oxygen. What CPAP does, which is different than oxygen, is that it opens the airway by blowing a small amount of pressure to open up that airway and keep it open like an airway split so air can get in. If people can't tolerate that, what else can we do? And so the option there is to put like a small little nasal cannula. If you've seen that little kind of little plastic thing that goes under the nose in people's, like in hospital settings or something like that, just kind of sitting right there, it just delivers oxygen therapy. And so it's reducing the burden of all those oxygen drops at night and kind of stabilizes the oxygen during sleep. So that's oxygen therapy. It gets attached to an oxygen tank, but not the real noisy ones because people can't sleep with those. But that's how it's delivered and it's used for treatment. Mhm.
So there's a high risk. This is to share go question. Yeah, children with Down syndrome, our first line still is considered tonsil and adenoid surgery, but there is still a very high risk of residual sleep apnea after tonsils and adenoids, and this is why we're partnering so much together, and there's a lot of research going on. We know the long-term impacts of sleep apnea and how detrimental it could be to all the different body systems, but we also know that especially in kids with Down syndrome into adulthood, that taking the tonsils out is a good first start, but not often the final solution. And so this is why we've brought in this discussion of, okay, well, how do we help kids? We've already taken the tonsils out, the adenoids out. What's the next step? Is there a machine they can wear on their face? Is there oxygen we can put to help with that, the oxygen level dropping in the system? And we'll kind of delve into some of the other options that are on the horizon and actually are approved through the rest of this talk as well.
Mhm. And one of the things we're trying to do in order to treat, right, and not ignore beyond CPAP, beyond tonsils and adenoids, what do we want to prevent? One of the biggest thing on everybody's mind right now, whether you have Down syndrome or don't have Down syndrome, is dementia. Can we prevent dementia? That's the biggest thing because we know sleep apnea is associated with some of the proteins that get deposited in the brain that cause Alzheimer's dementia. Those are amyloid and tau. And if you think about it, when we sleep, it's like the brain sort of cleans up and takes out the trash, that amyloid and tau trash. But when we don't sleep, so lack of sleep or have interrupted sleep, that trash never gets out of the body. So it gets deposited in the brain. And that's how we're thinking the theory is why people with maybe obstructive sleep apnea may develop dementia. Now, as you know, there's more increase in dementia in people with Down syndrome. And so the thought is, can sleep apnea be part of the reason why that is? Because we have so many people with obstructive sleep apnea who are not being treated. They have, adults with Down syndrome and sleep apnea have more MRI changes and more amyloid burden. So there's already some concern there neurocognitively. And that's apart from other cardiovascular potential results from untreated sleep apnea, coronary artery disease, arrhythmia, heart failure, like Dr. Shah had mentioned. And you want to get into this treatment part next, don't you? I think you're on mute.
Yes, so treatment. Laura, that's an excellent question. I think we can, the yawning, we can definitely tackle that maybe toward the end. Uh, so basically, what is our treatment? And it sounds like definitely people today, someone asked the question, can we still have sleep apnea after tonsillectomy? And the answer is yes. So we kind of have a stepwise approach. So what's our step in obstructive sleep apnea care? Evaluation. So we get a very thorough history from the family. What's sleep like? What are you noticing at night? Coupling that with the sleep study, how severe is the sleep apnea? Where does the sleep apnea score fall? We consider treatment of tonsils and adenoids, especially if they're enlarged. There's always a question in small tonsils, how much they're obstructing, and there's different techniques that we employ. even with children with small tonsils and sleep apnea, that we can actually do a test. We put a camera down the nose in while the child's sleeping. We set this up in the operating room and see how much blockage the tonsils, even though they're small. We talked about the tone, so meaning that the muscles of the back of the throat might be a little weak. So even these small tonsils can be kind of collapsing and flopping into the airway and still causing obstruction. After the tonsils and adenoids out, we strongly recommend getting a follow-up sleep study 3 to 4 months afterwards, seeing how bad the sleep apnea is, how much is better, how much is worse, how much is the same. We often see improvement, but some residual, because there are times that we're starting, if you look at the data, 50% are at that mild to moderate sleep apnea range. So if you start at a really high score, 30, 40, 50, 60, the chances of it getting down to 1 or 0 is pretty small. So we have to say, okay, well, this is a first start. Where are we ending now? What are other therapies? What are other surgeries? And what kind of follow-up care is needed? So once again, first step is often tonsils and adenoids, so TNA or AT, adenotonsillectomy. In the older population, teenagers and adults, there's something called a pharyngoplasty or a UP3. It's a very common surgery done in adults with sleep apnea, where once the tonsils are out, the uvula, which hangs in the back of the throat, and kind of the back of the throat muscles can be partially cut, and then you can put some stitches way in the back of the throat to help open things up. It's a it's a surgery that's quite difficult to recover from. It takes a few weeks. We do know that if the tongue is really large, there's some surgeries we can do to the back of the tongue. There's tonsil type tissue in the back of the tongue called lingual tonsils. By removing those, that can help as well. So in terms of adenoids and tonsils, so adenoids, what I quote families is, when I remove adenoids under the age of 2, there's often a 10-15% chance of regrowth. In terms of tonsils, there's 2 approaches to tonsils. One is total removal, called total tonsillectomy. The chance of regrowth in that is very, very small. I'd say less than 1%. There's also a technique where we shave tonsils down called intracapsular tonsillectomy, and that regrowth has been quoted anywhere from 5 to 20%. For children with severe sleep apnea, I don't offer the partial removal because of that question of, if it regrows, how much can we contribute to residual tonsil, meaning tonsil that's left over or grown back, or other issues. There's something called the hypoglossal nerve stimulator, neurostimulation, and that just received FDA approval for children with Down syndrome 13 and older. And so those children will have needed to go through tonsillectomy and adenoidectomy, failed CPAP trial. So we have to see if at least they can tolerate the machine. And if not, it's essentially an implant that's placed on the nerve of the tongue called the hypoglossal nerve. So it's a small incision in the neck here, and we actually find the nerve, and essentially is a pacemaker for the tongue that allows the tongue to kind of push forward in the middle of the night, opening that airway. Non-surgical treatments, CPAP, high flow nasal cannula, so the oxygen that Dr. Ibrahim was mentioning, some myofunctional therapy, so strengthening exercises of the tongue and the back of the throat, and weight management and exercise. So anything, if we talk about sleep apnea in general, we talk about what are our causes kind of inside the mouth blockage, and what's causing pressure outside on the neck, obesity, chest, with what's causing pressure on the outside. So if we, yeah, so these are awesome questions, and we actually made sure we reserved time at the end to answer a lot of these questions. So keep them coming, and we'll address them. If you talk about the efficiency and efficacy and safety of tonsillectomy in kids with Down syndrome, there was a study that looked about 384 patients, and we do know in general they improved by about 7.1 on the sleep apnea score, with the oxygen level dropping. So if it, say, for example, it went down to 82%, we showed that improvement on average of 85%. So the oxygen level increased by 3.14%. However, sleep efficiencies, didn't change much. So if they're moving all over the place or whatnot, that didn't impact too much. And the number of times kind of awoken the arousal index did decrease as well. So success rate still, remember, if we wanted a goal of AHI less than 1, it's still a small percentage, 16, but less than 5, so still putting in the mild category, about 57%. And of course, the risk of tonsillectomy, bleeding, having blockage of airway. And this data is, once again, from an abstract. So a lot of the details of the nuance of this data we're still waiting to come out. So high rate of OSA residual after surgery. So standard surgeries may not cure sleep apnea and Down syndrome. Abnormal sleep study after tonsillectomy and adenoidectomy can range anywhere from 48 to 63%. However, more surgery is not necessarily better. We have studies looking at tonsils and more throat procedures, similar, because there's many other variable factors. We say, well, what else can be contributing to this? Well, it can be age, it could be a whole other things. However, we're not the best at predicting it, because if you look at age or sleep apnea score or obesity, we can't say, hey, this child is at high risk based on these categories. So the prediction, our ability to predict these, is also very challenging. So if we look at why do children have persistent sleep apnea, so sleep apnea after any surgery, it could be asthma, age, or it can be, once again, weight related or multifactorial. So questions in children with Down syndrome, once again, tonsils and adenoids. So that's our first line, because we know that there is evidence of improvement. Is it going to cure? Well, this is why we're having this long discussion about sleep apnea in children, because we have to look at post-procedure sleep studies, so about 3-month post-op. We want to look at how high the sleep apnea score was before, what other factors, so was it mostly stopping breathing, slowing down breathing, what we call comorbidities, is there obesity, other risk factors, what symptoms are reported by families. And once again, at what point do we say, okay, well, this sleep apnea score is good enough right now to leave things alone, versus, okay, we need to do more. And once again, if it's mild, less than 5, we say, let's just watch, keep an eye on symptoms. We can consider some spray for the nose to help with some congestion. If there's mild sleep apnea with symptoms, so though the sleep apnea score was 3, we're still noticing poor sleep quality, long apneas, something is just not meshing with what the sleep apnea score is showing and what the symptoms are. Then we can start bringing in this new kind of newer procedures or newer sleep sleep procedures necessary. And then, of course, moderate, severe, more aggressive. I know we had a CPAP question, so Dr. Abrahams, can I kind of go through CPAP again?
Perfect. Yeah. And so when in doubt, pressurize the snout is what my attending used to teach me when I was in sleep medicine. And what it is no matter where the obstruction is, that pressure opens along. So it's not a local treatment, it's an entire airway treatment. That's why it's the most effective therapy for sleep apnea outside of adenotonsillectomy or getting those tonsils removed. But unfortunately, it's also the least used treatment. And so we have to have other treatments, but it is very effective for so we start with CPAP if we can. And so we do try to find we prefer nasal masks, not the full face if we can. So nasal mask, soft, something either under the nose, over the nose, just kind of, but it has to seal. And that seal helps pressure go in the airway and then open that airway up. So instead of having that closed airway, that pressure keeps it open. Somebody can breathe in and out and get their air as they sleep. And in retrospect, of course, looking at sort of people with both Down syndrome and non-Down, not having Down syndrome in children, pretty equal usage, at least in this one study, in terms of being able to use it. Some studies say there's poor adherence, however, and potentially some greater problems like leakage, et cetera. There's a bunch of data on caregiver experience. It's been my experience that caregivers are they have to be very, very, very hands-on for CPAP to work. And people do a very good job. And it's also really maybe a little overwhelming, especially at initiation for some. It's helpful when a parent uses CPAP, but when it's the first time they're learning about CPAP, help from education support groups is very helpful. Family modeling, if a parent uses, is helpful. Visual aids and storyboards. This is what we're going to do tonight. And, this is the next step is going to be this. We're going to turn on our machine like this. And so CHOP came out with a storyboard and some other visual aids that can be very helpful. Parents themselves may come up with their own storyboards by taking pictures of their own child and saying, these are the steps we need to take together. So there's also an importance of mutual understanding instead of pushing it on them, saying, we are going to do this to help you breathe, and having a lot of patience, understanding that there's sensitivity for sensory issues, that reactivity to the auditory sounds that may occur, or if just even the air blowing for the first time. Finding the mask is probably like the number one issue we have. Insurance is very challenging because they give you only one mask at a time. So we try to have our samples of masks in our clinic so we can have different ones or have other ways to get different kinds of masks so we can do desensitization and some other things. There are other things we could do to help children with Down syndrome use PAP therapy. In the adult population, there have been some studies. What are we doing? How are we doing? Are people with Down syndrome using CPAP? It seems also to be pretty similar with and without having Down syndrome, even long term. And in one study, we saw that one study looking at like up to 70% of children using it. That's a great number, but we do see that maybe dwindle with time. And over time, we can see some reduction in usage. And this is maybe a third of patients who may adhere or use CPAP. And in those patients, there were definite verbal and nonverbal IQ improvements, as well as some other things in terms of behavior, anxiety, sleepy scales, and mood. The ultimate thing that everybody says is it takes time. If we're going to do CPAP, we're just going to need that time. And sometimes still, despite that time, we still can't use CPAP, but we know it's going to take some steps for most people. And if not, then we can pivot and think about some of the other therapies that now are on the horizon. One you may or may not have heard of is kind of high flow. So it looks like the nasal cannula. It doesn't have to seal like CPAP does. So even if it wiggles a little bit at night, it's still delivering some high flow. This is particularly helpful for very, very young children. It's being used more now for adults. It can deliver oxygen or just the room air, but either way, it's still gently opening up without that need to seal. And so more and more people are thinking about using this as an alternative, maybe to CPAP or therapy. And we can never get by without, diet and exercise, right? Because if we can, like Dr. Shah mentioned, external factors, if we can minimize those external factors, we already have a compromised airway. Exercise has been proven to reduce the number of events at night when we have apnea. It's also the lean body mass can be helpful, as well as reduction in weight. And diet, the anti-inflammatory diet can maybe combat some of those long-term things we're seeing with people with untreated sleep apnea. Lastly, conservative therapy, and Dr. Shah mentioned this, is sort of doing some nasal sprays, or using Montelukast. People know that as Singulair. But what can that do? Well, that reduces the inflammation of the airway and sometimes reduces the burden of obstructive sleep apnea. There aren't too many studies in children with Down syndrome. One says it doesn't work after 6 months of treatment, unfortunately, and another one says it works in some. And I will say it's been my experience that it works in some. And so I don't want to say we don't have anything for mild obstructive sleep apnea. If there's any congestion, if there's something we can target, and they use it every night in terms of spray, it can help resolve some people's apnea. So it's worth a shot 20% of the time. In terms of, so what other thing here? I'm sorry, I'm getting ahead of myself because this thing got in the way of my screen. I apologize. So just to know that there are some medications on the horizon for obstructive sleep apnea. When people hear that, they're thinking, oh, thankfully I don't have to use CPAP or something. It's not as good. It's not as good. So we have to be really, really judicious. And these medications may not always come without side effects. However, we know that there was a study done in children with Down syndrome, very tiny study evaluating one of the medications on the market right now for obstructive sleep apnea. And the primary outcome, of course, was the number of times of the obstructive, that's the OAHI, apnea hypopnea index, meaning the number of times somebody stopped breathing per hour obstructively. Right. And so at baseline before this, about 7 times, and then going into low and high dose, about kind of, if we just say 4, so there was a slight reduction. Now that's a statistical kind of, whoa, that's great statistically, but is it really meaningful? That's the unclear part about this. And then the secondary outcomes, no major things, but interestingly, ADHD symptoms improved. But if you think about it, it is an ADHD medication that was used. And so that's not, that's not surprising. Dr. Shaw can talk about the surgical things here.
So lingual tonsillectomy, and I appreciate all the chat questions. I've been monitoring them while Dr. Ibrahim has been speaking, so we will address them. So when we talk about lingual tonsillectomy, if we look at how this is improved, and so there's a question in the chat, and I do want to highlight that is, if kids with Down syndrome still have sleep apnea after tonsil surgery, why even take them out? And so where we want to get to is definitions, right? So anyone with an AHI greater than 1 has sleep apnea, but there's 2 things. It's either what we call residual sleep apnea. So if you have an AHI of 60, meaning you're stopping breathing 1 time every minute, and you go down to 30, you still have severe sleep apnea, but the sleep quality, you're dropping the number of times you're waking up in half. And so there's improvement, but still residual sleep apnea. So that's the hard part, is that they're still defined as having sleep apnea, but it's better than it was before. So so that's why we're marching towards all these other options of it. How do we get better, and how do we get better, and how do we even cure? And so that's a continuum that we constantly have to keep working on, because there's all these external factors that we've spent this time talking about and that we need to be mindful of. So lingual tonsillectomy is usually reserved in children who've had tonsillectomy and adenoidectomy and persistent sleep apnea, meaning sleep apnea still, maybe not as bad as it was when they had tonsils and adenoids, but still qualifying as sleep apnea. So the lingual tonsils are in the back of the tongue. When the back of the tongue drops in the back of the throat, these bumps of tissue, the lingual tonsils, can obstruct the airway, block the airway. And in this surgery, it did show that there was quite an improvement from pre-surgery HISO 9 down to 3. So we go from moderate sleep apnea to mild sleep apnea. And in 61%, we achieved less than 5, and in 19% less than 1, so that would be considered cure. And the oxygen level went from 84 to 89%. And so this is a recent study by a large group of ENTs in 2021. So glossectomy is a little more aggressive. Great question. Glossectomy and lingual tonsillectomy in obese and non-obese. So if we actually remove the lingual tonsil, so the bumps, and actually remove a part of the tongue, either what we call radiofrequency ablation, so like shrinking it or actually removing part of the back of the tongue, there's actually quite a bit of improvement. There was AHI cure in normal weight patients, but in patients who were obese, there was no change. So these are pretty aggressive procedures, though. So someone had asked about dental and a jaw revision. So there is studies in some case reports in kids and younger adults with Down syndrome about rapid maxillary palatal expansion. So actually using appliances and expanding the palate the whole goal of expanding the hard palate is to improve the nasal airflow. And there has been case reports, and that's always the hard part, is that when you take one patient success story, it may or may not extrapolate to all the patients, but that is a promising part of the collaborative care we're talking about. And then someone also had asked about OT and sleep, I think mainly for CPAP, but orofacial myofunctional therapy, so strengthening the throat and the tongue, definitely, once again, in a week intense oral myofunctional therapy, there has been some marginal improvement with no AHI. But once again, this is 1 week in a very small case series. So we are really broadening to try to bring all different specialists and expertise to help with this.
Mhm. And sometimes we'll combine different things, right? So we'll combine intranasal corticosteroids to improve that nasal breathing, and then or facial functional therapy too. Mhm.
The other thing is what we call relative macroglossia. So there's we actually can do kind of MRIs of the kind of tongue and brain kind of during essentially almost like a sleep type state of the tongue dropping back. And the hard part is in when we look at children who've had tonsillectomy but still sleep apnea, abnormal AHI, what we notice is the tone of the tongue dropping back, what we call hypopharyngeal collapse, of the muscles of the way back of the throat squeezing and blocking the airway. Once again, recurrent enlarged adenoids, not tonsils, so adenoids, 63%. So someone had mentioned, yes, adenoids can grow back. Lingual tonsils, back of the tongue, and then macroglossia, that's large tongue. So we have large tongue and glossoptosis, which is tongue flopping back. And relative macroglossia is true, more than true. So it's the size of the tongue relative to the entire face. So now we talk about what we call hypoglossal nerve stimulator. Inspire is now the approved brand that we can implant in children with Down syndrome older than 13. The goal of this is called what we call neuromodulation. So it's essentially, I like to say, like a pacemaker for the tongue, and that can be activated during sleep to keep the tongue pushed forward to allow the airway to stay open. And this produces what we call dose-related increase in airflow by stimulating the tongue during inspiration without waking. So it's essentially like a low kind of impulse to keep the tongue open, but not so jarring that the tongue juts out and wakes the patient up, the child up. So these are some success stories with this. So this was a very recent study. It's probably for the last 7 to 10 years, there's a ENT named Dr. Hartnick. He's in Boston, and he really has pioneered and worked very hard on getting indications in the FDA to approve this therapy for children with Down syndrome 13 and older. Ideally, we can do it younger, but 13 was actually a great win because of everything we've talked about. We've done tonsils, we've done adenoids, we've tried CPAP, we've tried all these aggressive procedures for the tongue, we've tried dental, we've tried jaw, but it's still not working. So then we talk about Inspire, and this has been proven success. This has been proven to be successful in adults with sleep apnea, and so it has been brought over to children with Down syndrome only. Children without Down syndrome with sleep apnea still are not approved for this procedure. So this is So basically, if you look at kind of the first patient who had this, it was really a life changer, a game changer for him. It changed his life, and he uses it every night, and it's helped him so much. So next slide. So basically, this is the study that showed the results here. The AHI, once again, even with this, you take the children with Down syndrome and sleep apnea, they went from a 23 to 11. So by all means, still having sleep apnea, but much improved. And if you look at ESS, so the kind of the sleepiness scale, much better. And so that's kind of the functional aspect of sleep apnea. And so in these kids, these are 42 kids, remember, very small study, had to have severe sleep apnea post-TNA, previous tonsil and adenoid surgery, intolerant to CPAP, and once again, no central apnea. So what's our future trajectory with this? Well, we estimate about 6,000 babies are born with Down syndrome every year. There's about 30,000 children in the US age 13 to 17. We estimate about 18,000 have an HI greater than 10. 11,000 adenotonsilate is not effective, and 5,500 intolerant to CPAP. So there can be a very large population out there that can benefit from this. So the takeaways, and once again, this leaves us some time and we'll make sure we answer questions. So OSA and Down syndrome is very common, and early detection and intervention may impact long-term outcomes, especially cognitive. PAP compliance can be achieved, but with a lot of hard work, and when it's not, now we have other options. And growing research will help guide additional evaluation and management opportunities. And with that, thank you. Let's go through some questions here. I know we addressed some, but I'm gonna kind of go up to the top, and Sally or Dr. Ibrahim, and between you and I will kind of tackle these. So we answered was oxygen.
Great.
Yeah, we talked about the sleep apnea after tonsils and adenoids removed. So excessive yawning. Dr. Ibrahim, do you want to take the yawning? Because I have my answer.
That's that's one of those things we do and we don't completely understand why we do it as human beings. The thought is that our brain is telling us that we need to breathe and so the yawn in itself increases our rib cage and gets the oxygen and CO2 out, oxygen in. And so when we're tired, that may translate into I need to breathe or something like that. And so you'll often see that when people are tired. We still don't actually know and understand the complete mechanism.
That's kind of my answer too. So this is a great question. How common is to have a negative sleep study at age 4, then sleep apnea several years down the road? Should we repeat a sleep study at a certain age regardless if there are concerns or not? I get this question a lot. So my answer is, one, if we've had a negative sleep study and we say, okay, you're not noticing any apneas, you're not noticing any behavior changes, you're not noticing any struggles in school, and there are not any new risk factors such as increased BMI, any other risk factors, I'm okay with having a shared decision of kind of monitoring clinically. The data would show, since we know that children with Down syndrome into their teenagehood and adults are still high risk. Do you have an age, Dr. Abraham, where we might want to repeat it even though clinically things are going well?
I love that question because I don't know if the research doesn't show what that age is yet, I think, based on, and we had this discussion even in our hospital system because of the screening guidelines, and we have a clear guidance in children. And then after after they're, very young, what do we do? And when do we evaluate them again? I think in a high risk population, we do have to, and I would almost say like around that, teenage time, because they've sort of stopped growing. And then if but we have to really be either symptom based or comorbid based. So if there's hypertension, and I think there's this question here about why it leads to high blood pressure, which I can touch on.
Great, yeah.
Mm-hmm. And so perhaps I can dive into that right now. And
perfect. Yeah.
When we sleep, we go into a cardioprotective state, meaning that we go in and our heart is protected because we get into a resting state. And we see this on sleep studies. The heart rate kind of dips and the blood pressure dips. And so your blood pressure, heart rate different from sleep and wake. The opposite is true in sleep apnea. Typically, every time we stop breathing, there's a surge, right? Because the brain says, I need to breathe. So what happens is the flight or flight. So the sympathetic tone goes up, meaning that the heart rate and blood pressure also go up. And then there's a rebreathing, right? And so even when we're doing this during sleep, there's these jolts of higher pressures, even for a moment. But that translates into jolts during the day. And so people can have that high blood pressure during the day. It can also have some other, heart modeling effects on the body over time. Mm-hmm. I hope that answers that cardiovascular question.
So then we talked about a little about dental, some of the case reports of the palate expansion. I'm not as familiar with jaw surgery. There's not a lot of data. There's a lot of data in adult literature about jaw surgery and health, like non-syndromic healthy patients, kind of jaw investment and mid-face advancement for sleep apnea. But uh, there's another question about, so yes, so large tongue and tongue flipping back. So there's multiple, there's macroglossia, which is large tongue, that's just in general. Tongue flopping back is called glossoptosis. And then what we call relative macroglossia is that there's a small mouth, but a large tongue. But if you took that tongue kind of out of context of the body, it wouldn't be like a large tongue. So in terms of surgery, there is a little bit a difference. So if there's a large tongue, some of the surgical history is actually kind of reducing some of it by actually removing part of it. I don't tend to do that in my practice. I actually think it's pretty barbaric, and I think we have so many other options. And the tongue flipping back, that's that glossoptosis. That's where this Inspire can really help, because that's the tone of the tongue and it keeps the tongue forward. The lingual tonsillectomy, by shaving kind of the back of the tongue without removing it, pretty much the goal of that is when the tongue flips back, there's a little more room back there than there used to be by removing some of that. Bleeding as a complication of TNA, anywhere from in non-infected tonsils, so children who have not had recurrent tonsil infections, it's about 1 in 50 to 1 in 75. With infections, if there's an active infection or a lot of strep throats, it can be anywhere from 1 in 25 to 1 in 50. It just depends how inflamed and how old they are. Why is Inspire implanted only device approved for kids with Down syndrome? That's a very tough question. Is the question, as opposed to kids, just kids in general? Is that the question?
I would assume so.
Yes.
Yeah.
Hey, Dr. Shaw. Yes, it is. I just wondered why it wasn't approved for.
They even get this trial going for children. The hardest part, Amanda, about research in children is that they can't consent for themselves. And so getting protocols to do research and implant a device is extremely difficult. And so any new devices, if we talk about anything that gets approved in children, it takes often many years. And so the hope is that we talk about risk and benefit. And so since the risk of residual sleep apnea is so highly noted in kids with Down syndrome, we were able, I wasn't part of this study, but my colleagues, we were able to get exemption. So Dr. Hartnick was able to get almost like a compassionate use, and did a few cases then, and then was able to get kind of more data and more children. And finally, the FDA said, okay, well, we have enough data from here. More trials are going to go on. And my goal and my hope is it's going to be approved more.
And if I could tag on maybe the kind of the understanding as to why it was pushed in that direction, number one, like Dr. Shaw mentioned, the high prevalence, and so we needed another therapy, and then number two, the macroglossia that we see in children with Down syndrome. Number three, the tone, and so it takes care of the tone and the tongue. It's the one treatment that can do that, where we stimulate that tongue to go forward and up and away from, and move it off the back of the throat to open up that airway. And so I imagine, and we were talking about the Inspire folks, that we will also probably be seeing this in other children with tone issues and maybe some tongue base issues in the future. But this was it was a remarkable thing that really people pushed for, having this therapy for children who are going untreated.
Summer had a good question. So after TNA still has sleep apnea, when do we do surgery or CPAP? How do you decide if next step is surgery or CPAP? So all great questions. So if child's 4 or 5, it depends on the score. And I obviously work with Dr. Ibrahim in sleep medicine to see, okay, if it's mild, moderate, or severe. If it's mild without symptoms, we talked about kind of nasal sprays, watchful waiting. But if it's severe symptoms and severe sleep apnea, we can do what we call a DICE, which is a drug-induced sleep endoscopy, checking airways while asleep. I will offer the lingual kind of tonsillectomy, so kind of shaving down, but not aggressive. For kids 4 to 5, we can talk about CPAP. Obviously, compliance can be difficult. And yeah, if the child's only 4 and far away from Inspire, that's a big challenge. And so this is why we get sleep studies. We try our CPAP. We try the therapies. And the hard part of, say, implanting a 4-year-old, for example, part of the hypoglossal nerve stimulator, there's a lead to the chest and there's wires that go up to the tongue. And so as you grow, those wires are going to stretch and not be used. And any sort of implants in little ones, it takes a lot of that takes a lot of approval process as well.
And thankfully we have things, and that's one of the reasons why there's that the DOSA study looking at children with Down syndrome post TNA who still have at least moderate. And so I think the consensus is, yes, moderate, severe, we definitely want to treat. It's that mild category that maybe very clinical, and it has to be really a team-based approach with the caregiver. And looking at all the other comorbidities to make the decision, do we need to be aggressive? Do we need to have CPAP? Do we need to do more surgery? Do we need to do something else? And the something else right now for that age group is potentially oxygen. Although the study doesn't start till age 5, but nonetheless, it captures the kids who are not being treated until, in that 5 to 17 range. And then there was something about, there's another chat question about the Apple Watch and Fitbit and reporting oxygen levels during sleep. They're getting better. We used to poo-poo that. No, don't do that. Bad data. I'll tell you that it's getting better. And so some people want that data and want to be able to watch their loved one or something like that. I will say though, that movement very much affects it. And so even when I'm reading sleep studies, I have to look at what's called the plethysmography signal, because I can get an oxygen that looks terrible. But if I don't have a good signal, I know that's bad data. You don't get to have that raw data in front of you when you're using an Apple Watch, but so you don't know the accuracy of that all the time. So just buyer beware.
So great question, Summer, about laryngomalacia. So part of what we do, so if I have a child with persistent sleep apnea, both with Down syndrome or without, if I have a child post tonsil and adenoid surgery with persistent sleep apnea, I have been doing the scope while asleep. And if there's a laryngomalacia, which still can be present, there are treatments we can do for that. And we didn't actually tackle that in this talk, but there are different tightening procedures I can do. So not necessarily related to gagging more, because that's not necessarily larynx, that's more pharynx, but could be contributing to sleep apnea.
And then there was another question about inclined sleep. And it is true that maybe a 45-degree angle or more, but as you get angled, you might actually lock you might get your neck into your chest, which actually obstructs more. And so there has to be this fine-tuning angling, which is hard to do in a bed. We have heard of people getting into a recliner chair and sleeping better, and but we don't recommend that all the time. There's been some studies, but not a lot. And nothing that I've seen, at least in a rigorous way for children or adults with Down syndrome. But we know that what sleeping inclined will do is take that tongue from going back into the throat and the gravitational pull is less on the back of the throat, more in the upper part. And so it doesn't obstruct as much. It's a conservative strategy along with some other things. And then there was a question about the device. What does it feel like? Can you feel the electric stimulation? So when we first said, I don't implant, that's Dr. Shah, but I see them after their implantation to do the device, interrogation, et cetera, and start turning it on. I do that for adults, and in the future for our children with Down syndrome. And so what people say it feels like is they actually can't say how it feels in the beginning, and then it's a slight stimulation, and then they often say it feels weird because their tongue is moving and they're not moving it. It doesn't hurt, it just feels quote unquote weird is what that sensation is. Anything else, Dr. Shah?
My understanding in talking to the Inspire activation is that the goal, they set it so they titrate it. So essentially they'll start at the lowest stimulation possible to get improved outcomes. So there are kind of follow-up sleep studies. And my understanding, once again, because this is very new, is that it won't feel it. It'll just kind of essentially bring the tongue forward, but shouldn't be so sensory that it's going to cause significant issues.
Right.
Um,
Because it's
the
happening during your sleep. If you wake up
yes,
and feel
exactly.
it, then it feels awkward, but it's like, oh, okay, but otherwise it doesn't wake people up. Mhm.
Yeah, and in adults who have it, then usually when they get up and wake up, they're able to click a button and turn off the Inspire, get up if they have to run to the restroom or whatever, and then turn it back on. So, um, there's a question. Having tonsils out may not cure 100%, but it could take severe to mild or less. Absolutely. Um, so the question is, what percent of kids are the kids it doesn't help with? So therein lies some of the studies that have been there. We're all over the place in terms of the ability to predict who it's going to help. We know it's going to help the majority to at least maybe go from severe to moderate or high severe to low severe, but that's where we look at other predictor factors. How's their weight? What other were they premature? What is their asthma? Any lung disease? But once again, it's a crystal ball effect. We won't know, but at least we can. I'm very honest in general when I have a sleep study and say, hey, this is the first step. Like this may help. This will likely help, but how much we have to know afterwards. In terms of airway surgery, there's a supraglottoplasty for the larynx for laryngomalacia. There's actually more type of what we call epiglottic surgery called epiglottopexy. It's multiple airway surgeries, but what I worry about in my children with Down syndrome and young adults is that anytime you mess with the throat a lot, it may not lead to gagging, but it can affect some swallow, it can affect liquid entering the airway. So I'm just a little more cautious on any more aggressive throat surgery.
Mhm. There was a question about I think the study. One was, do you have to fail CPAP to get approved? And then the other one was, can you talk more about it? I think pros and cons and considerations. And so you can fail CPAP or you may not want to pursue it, either one, because we know that people hesitate to do CPAP, and what can you do in the meantime? And so people hesitate for 1 or 2 or 3 years. And so it's an opportunity potentially for people who just don't want to go there and don't have the time to do it to be able to say, but you also have to have the time to do the study. So, to each his own pros and cons, or it is time, it's a commitment. I always tell people that when they're involved with research, that at any time you can say, no, thank you, and you can exit away. When you're going into research, of course, I know people want to commit, but if it becomes hard to commit, then of course, you don't have to. But the pros are, you can see if sleep apnea if sleep apnea, yes, is present, because we are doing research sleep studies. And so in our screening protocol, if we don't have a prior sleep study, but we think we have some sleep apnea symptoms, we can do a research sleep study. The other pro could be to trial oxygen therapy, because in the sleep study, we'll see if oxygen works for that sleep apnea or not, and to see if you fail that oxygen or not. That's part of that protocol. The other part of the protocol is to do some sort of thing. So neurocognitive testing, looking at the heart, and getting that information might be helpful for some families. So those sort of some benefits, some unforeseen benefits might be, to the greater good in terms of, does oxygen work or not? It is a randomized control trial. So the potential con could be you're not randomized to the oxygen arm. You get all those goodies, and then you get tested for oxygen, but you may not get into the randomization with oxygen. I'm actually blinded to who's in each arm so that it doesn't skew the results. And so that's, it's helpful to know, because some people will get conservative therapy and actually do okay. And we have to know, does oxygen work in comparison to that conservative therapy? But at the end of all of that, people can be potentially put on oxygen therapy if it is effective. So I hope that answers the question. But if you want more information, I'm happy to send, there's handouts and some other things, or reaching out to me. There's also the dosatrial.org. The other things are, and Dr. Shah, this is, I work closely with ENT, very, very closely with Dr. Shah, and because, and other people from other institutions. And how do you decide the next step on surgery? This is such a personal thing, because what did their sleep apnea look like to begin with? How are we doing symptom-wise? What are our comorbidities? How aggressive can we be? Are there sensory issues? Is it a surgical case? And so this is where the DICE becomes very helpful, because DICE is not just for that maybe tongue-based operation, like Dr. Shah mentioned, looking at the airway to see what other parts of that airway are obstructing during
Like adenoid regrowth, I know that had been brought up a lot. The camera starts in the back in the nose, so I'm able to check all that. And so, yeah, this is why we all talk together. Every family knows their child best and will know what's gonna be best for them. And I think we have a lot more tools now than I think we did, but we also have to be mindful that everything we do comes with risks and benefits. And so I'm very mindful of treating children, that what we do at the age of 6 can possibly impact the next 50, 60 years of life. So we have to also think very deeply about what we're subjecting young children to, because they have a longer life ahead of them.
Oh, thank you so much for having us and for
Yeah.
all these very good questions.
Yeah, very good question. No, yes. So.
Oh, thank you. Thank you so much for your time. That's great. So, Dr. Shah, have you actually used the Inspire at Rainbow?
We have, so ironically, when I was a resident now 11 years ago, because a lot of my training was first in adult medicine, then I did more peds. I was part of some of the first adult Inspire trial patients 12 years ago. We have our first child with Down syndrome. I partner with Dr. Fleury, who's our adult sleep medicine, in end of March.
Very exciting.
So,
well, good luck.
Yeah. So
thank you. This was great, and I know we had a great turnout, and I just appreciate your time and your answering so many questions. And thank you for everybody who attended. And this is great. We will get this recording edited and up on our YouTube channel, so even more families will be able to access this great information.